Welcome, everybody.
Good morning. Welcome. Thank you to everyone for attending today. This is day one of our 2026 Spring Graduate Colloquium. This is a really exciting week where our Aspen and USU doctoral students have the opportunity to showcase their hard work in research and projects. We look forward to engaging in a thought-provoking discussion and support the next generation of our scholars. Day one of our colloquium begins with Dr. Andrea Flannery, who will be presenting on her project related to obstructive sleep apnea syndrome. So let's go ahead and welcome Dr. Flannery.
Hi, everyone. Welcome. And I'm glad that you all could be here. This was a very exciting project for me and continues to do so. So I'm really very excited to tell you about it and also kind of give you some information. So my project is titled Obstructive Sleep Apnea Project. Very basic. A little bit about me. I'm a family nurse practitioner and perioperative nursing leader with 25 plus years experience, although I won't tell anybody that, and 10 years of advanced practice. I am an ACP manager, previously assistant director of periop services for the hospital, but when we changed everything offsite, I moved titles. So I run the offsite pre-surgical testing at South Shore University Hospital, which I'm very proud of. Um, I am an adjunct and clinical instructor for Hofstra, Malloy. I was previously SUNY Farmingdale and Suffolk Community College. So again, this is very exciting because some of my students know me, and when I graduated and became a DNP, it was just an amazing situation. So a little bit also about my education. I did get my DNP from Aspen University, my master's in family health from SUNY Stony Brook, and I'm board certified. And I currently lead and led the NP pre-surgical testing unit, which is offsite, which is again so very exciting because it was a project in of itself. And I've standardized evidence-based protocol, preoperative workflows. I mentor people all along from high school students all the way through NPs. And my clinical strengths are perioperative care, acute response, and cardiology. Also ACLS, BLS, PALS instructor, and AACN, and skilled in venipuncture and ultrasound guided IVs. So I definitely have some background. This is our biannual graduate colloquium. But basically we're speaking about my research, my presentation, which is implementing the Stop Bang offsite screening tool. I was awarded a poster award for Catholic Health Services in evidence-based practice and nursing research, and I did a podium presentation for Sacred Heart, which was really exciting. And I hope that some of the students watching will know that, it's very important for you to present your information and get your stuff out there. My hobbies are, I do a lot of community outreach and mentoring with students. I crochet and do Pilates. I rock paint, which is my stress relief because I am a proud mom of four. I have one son in the Navy. My daughter just became an RN, and I have a grandbaby on the way, so it's very exciting. So what about OSA? It's an underdiagnosed symptom. It's associated with very many serious comorbidities, and there are some delays in diagnosing obstructive sleep apnea, which is important and scary at the same time. There's gaps in preventative care, and there's no standardized screening in some of the primary care offices that I've visited just to see if they actually do the OSA screening tool which is kind of scary. In this project, I worked on implementing the stop bang screening. I targeted adults that were 30 years of old or 30 years of age or older. We chose that time frame because at that point we wanted to see where we wanted to take it. We identified our high-risk patients and our population, and our goal was to improve referral to pulmonology and enhance patient outcomes. So hopefully you'll get to see that piece of it. This was my PICO question. Does implementing a nurse-led stop bang screening in adults 30 years of older in a primary care clinic compared to no systematic screening increase identification of patients at high risk for obstructive sleep apnea and referrals to pulmonology over 8 weeks in an 8-week time period? So this was the PICO question, PICOT, and exactly speaks to that. Adults in primary care, stop bang screening, no screening, increase identification, and in an 8-week period. Our framework that we used was the PDSA, and Orem's self-care deficit was a very mild and easy thing to understand. We wanted to support the patient engagement, and we wanted to also guide our workflow integration into the office that I was working with. So it made it a little bit easier to address when I had the right framework. So some of the background to OSA is linked to hypertension, cardiovascular disease, diabetes, and cognitive decline. And often, most times, this goes undiagnosed, and that's a problem. So we wanted to make sure that we captured as many people as we could for the time that we had, and also the high-risk population that were missed when we did the testing. So some of the samples studied, like I said, we did the primary care clinic. We had patients over the age of 30. It was an 8-week implementation. We screened about 65 patients, which was a decent amount. There was no prior standardization or screening or referrals. It was kind of hit and miss, so it made it a little bit easier for me to kind of designate and show them how to do some of the education. And some of the demographics were not detailed in the report, but we focused on screening the high risk population. So why stop bang? It's a validated screening tool. It's quick, it's easy to use, it's highly sensitive, it's been around forever. It works very well in the busy clinic and identifies the patients at risk right then and there as you're speaking with them. So it was very easy in the office to see them, and I was very, I was in the office with them. I kind of walked around. I gave them some education if they needed it. It was easy to talk to the patients. So like I said, it was a very quick and easy, simple use tool. So the aim, again, this is a repeats, just implement, it was a nurse-led stop bang screening in the primary care clinic. I worked with one of the physicians. We really wanted to facilitate timely pulmonology referrals in that 8-week period. We did use the Plan Do Study Act and the Orem. And again, this goes over, the Plan Do Study Act, what we wanted to kind of understand, develop the protocol. We did a staffing education in the first 2 weeks. We EMR documentation in the fields that we used, and then we had a referral pathway right then and there as the patient was in the room. We launched screening during routine visits at weeks 3 and 10, and we tried to get as many patients as we possibly could. In the first, you'll see when I go through my timing, some of it started off slow, but then as people realized why I was doing what I was doing, they answered the question and was very easily identified. Most of the patients were from Spanish speaking, so I did have to have an interview and have somebody there with me to help, but it was very supportive. They were wonderful. Um, and then weekly audits of the screening counts just to make sure that we were doing what we needed to do. We looked at our high risk rates and the referrals that we were able to complete. And although that wasn't one of the necessary things that we were waiting for, but we did do that. And we looked at when we did the weeks 3 through 10, we kind of refined the workflow a little bit more and planned the sustained adoption of the whole thing to make sure that the office understood what was necessary and how they could sustain it through after I left. So again, staff were educated at 1 to 2 week. We did the stop bang training. We had a questionnaire that the staff did, and then also went over an instruction sheet. And then the EMR documentation training, again, they had to input most of it because they had a different EMR that I was used to. So I'd have to hand them the sheet, and they would have to put it into their EMR. But there was a great workflow. We had an interesting, conversations going back and forth. So there was definitely some communication. And then we screened during their visits that they were there for the patients. So again, what did we look at? We looked at the stop bang scores. We looked at the EMR documentation. We had weekly screening counts. We had referral tracking and high risk classification. It made it very important, so we were consistent and went through everything the way that we needed to for the project. So who screened? It was either myself, it was the nurse practitioner that worked with me, the medical assistants, and they were the ones that actually helped enter into the EMRs. We had to be HIPAA compliant in our storage, printing forms, scanning, and retaining per policies, making sure that we had everything compliant with school and also with the project. We had the weekly audit logs to access, control, and encrypt in place so that way it wasn't, you couldn't lose or misplace, or at least have access to the weekly logs other than what was given in the unit. And we also spoke with the office to plan retention and destruction per the organization and the school's policies. So we wanted to make sure that we did everything correctly. It was appropriate, and we made sure that we had everything that we needed to move forward to do our management of these patients and their records. So this is actual results. What we did, we screened 65 patients, how I screened 65 patients. We did 30 of them were high risk. So that was about 46% of the patients screened, and 100% of those patients were referred to the pulmonology office, which is fantastic. Baseline was no patient screened, so it definitely did make a difference, and it was very exciting to watch it all unfold as I was doing my project. So it made a very significant practice change and made it very easy for the staff to proceed with staying with it. So again, it was definitely a very welcomed project. Some of the weekly trends that we looked at were the gradual increase in screening. So again, when we first started out, it was a little bit rough. I think I had a 1 or 2, 3 or 4, and then by week, by previous weeks, it went up very quickly to 3 to 5 high risk patients per week. So it made identification for these patients easy, and it was a easy, stable workflow. It didn't make them have too much stress on the team, because I know that that was one of the biggest components in the office, was it being very stressful for them that we were adding something else to them. But really, it just was a quick questionnaire. They were able to answer the question, and by the peak weeks, we saw like 12 to 13 patients, which definitely made me very happy. So the staff and workflow impact, like I said, it was very minimal disruption to the workflow. It was, the office was a little resistant at first, made it very uncomfortable. But again, you're doing a project, you're implementing something, and it was, I tried to make it as easy as possible for them so that it wouldn't be that uncomfortable. So again, we integrated it with the vital signs when we were going over with the patient, and made it very easy for the staff. It improved staff confidence, so they were able to do the questionnaire very quickly, and then easy to implement for me and the staff. And then after a good couple weeks, the staff was very much more engaged, and it was a strong team engagement. So that helped me out tremendously, and also helped the patients out. So, and that was my goal, is really to support the team, but also support and make sure that we had everything that we needed for the patients and their accessibility to this project. Some weekly patterns that we had. Again, we did 1 to 2. We did the staff orientation. Initial was small numbers, and then, like I said, we started off really weak, but then by weeks 3 through 8, we were able to see peak at 13 and 14 patients by week 7, and then your high risk patients were again identified. That integration with that communication, that interpretation, really helped support everything that we needed to do. And having that background from the training to the full launch was definitely something that made it very easy and more comfortable for everybody and the team involved. So it didn't make them uncomfortable, didn't make them upset, because in the beginning they didn't want to be involved with any of it. But supporting them really helped identify some of the high risk patients. So it's some ethical considerations when it comes down to it. It's a minimal risk QI project focused on quality of care. We had privacy, confidentiality was always maintained, and equitable access across to all the patients that were walking in. I utilized the patients that were coming in for their visits. They were very much appreciative. They were encouraged to have a conversation and then asked questions, which was really interesting. Having my questions being answered or their questions being answered made it so. It was wonderful, to have that opportunity to show them exactly that we're here to help. We're not here to give them problems. So again, it was a very great project. We looked at the beneficence versus maleficence, emphasized referrals for high-risk patients. So again, it was definitely a great project that I enjoyed. Again, we looked at the minimum disruptive. We wanted to make sure that the staff gave me good feedback. this was the most important, that the staff reported increased confidence and comfort in the training, and that the template that they used was easy for them to use. So it also helped to trigger the referrals, and it made it very easy for me to get the information from them. The interpretation and the impact, the screening, the systematic screening that we did was uncovered a lot of unrecognizable sleep apnea patients, which really, which we all know is out there because patients come to me all the time when in pre-surgical testing, and they say, yeah, I screened positive for sleep apnea and I didn't want to I don't want to do the mask. I don't want to do any of that. But they just don't recognize the opportunity that will help them down the line. And that's part of my next project, which hopefully we can start implementing. But this is a nurse-led protocol. We looked at the early identification and referrals at point of care, and it definitely does align with Orem's theory, improve patient self-care engagement via risk awareness and timely specialty evaluation. And again, a lot of the communication that, when we gave patients their information, they didn't realize, some of them, that they needed to understand what sleep apnea was, why they had it, how well the education is, and teaching them really was the impact, to help them tremendously deal with their sleep apnea. Because, like previously stated, looking back at how high risk some of these people are, they had no idea that they even had a problem. So unless their family members, oh, he keeps me up all night, sleep, I hear him stop breathing all the time. There's nothing I could do. But we gave them some information. So that was the goal, and I was kind of happy to see that a lot of that happens. So some of the things to take away with this is it was a small sample size. It was only an 8-week session. It was a single site study. Really was, study is not the right word, but it was a single site evaluation. Short time, 8 weeks, no long-term follow-up. That's one of my things that was my burning concern, and limited generalized availability for the sample size. So it just things we could have done to move forward if we needed to, and taken it to the next level. So in sustainability and next steps, I would have loved if they would have kept up with the project. And we want to integrate it into a routine intake. I was in a primary care office, so I'm not sure if they did continue. I did follow up and ask them how they were doing, and they said they were great. So, but again, it's not my office. Continuing staff education. So if there was any questions, they were able to contact me. I would love use the EMR prompts. Like if the EMR that they had didn't have an opportunity to stick it into the EMR appropriately, they had to put it in as a separate thing. So it would have been much easier if they were able to just have a click of a button and say, yep, this guy's positive, or this guy's, negative, or what was in between. And then monitor the screening rates. So looking at taking this for a 12-week session or a 12-month session, it would have been nice to be able to see how they fared with the screening if they were positive and it was 12 months. And then also I would love to have expanded to other offices or given my information to the other sites, just to kind of make sure that everybody's doing the screening in sleep apnea, because I know from bringing in my offsite pre-surgical testing, the patients a lot of times will say, yeah, not so much, yes, I was already screened for sleep apnea, but they may not be asking the right questions, or maybe they're not given the right information. So, just giving them um, education is important. So we try to give that to them as they come up positive. And then if also share it with the primary care offices that are working with us, just to let them know that their patients are positive. And that's my goal, or has been my goal. Some visual recommendations. It would have been nice to be able to do run charts, weekly screenings, high risk counts for the staff to see. I did let them know, but it would have been nice for them to be able to look at that on a regular basis. Do a process map, which screens referrals, workflow in the EMR, so as someone comes up positive, then they could just click the button and process map it and say, this person's positive. It would have been a great recommendation on my end. And then one slide, stop bang summary, make it, this is what you're doing, this is why we're doing it, and then cut it off. And then do a bar graph, baseline versus implementation, like how well we've fared in the 8-week session. I would have loved to have seen it go a little bit further and then take it to the next level, whether it be a whole year's worth, to see how these patients are doing and how they screened. So some of the take-home message, this was a brief nurse-led, evidence-based screening protocol, and it's called Stop Bang, was feasibly integrated into primary care. We had a 46% at high risk and achieved 100% referral among the positives within the 8-week period. Practical, it's scalable approach to reduce underdiagnosed and enhance the preventative care for OSA. Again, it made it very simple, and it was one of those take-home messages for the patients, the staff, and the clinicians to make sure that they saw and had a good knowledge base for what we were taking care of in the office. Some of the statistical analysis, some of it was not applicable. It was no continuous outcomes. It didn't, we could have kept on going, but we didn't. Looking at week to week screening, high risk, the referral, looking at inferential stuff. So we could have taken further in some of these in this project, but it was really just a QI intense. So process change and yielding some of the information. So in conclusion, this was a wonderful nurse-led stop bang screening. It was feasibly integrated into primary care. We did see 65 patients that were screened in 8 weeks, and 46% of those patients were identified as high risk. The systematic screening addressed clear detection gap, so we could have kept on going, or we could have done early identification and referral for some of these patients. Aligning with Orem self-care and the PDSA supported patient engagement, which was really impactful and really improved the education, especially when we were in the offices and we're talking to the patients and having the conversation and making sure that they understood what was going on. And then provided a practical and scalable model for preventative screening in this very busy clinic. So it made it very simple, practical, complete, and made sure that we had the right patient route, right information, and communication. So some questions that, this is a busy slide, but the takeaway is, how many high-risk patients completed sleep study? That would be the next question that I would have asked, like how many actually went, who followed up, who was the treatment adhered, what kind of proportion of those patients were initiated the CPAP or any other alternatives? Did they have surgery at 3 and 12 months? What were some of the clinical outcomes? Did it help their blood pressure control? Did they see a difference in their cardiovascular or their metabolic markers? Was it their daytime sleepiness decreased, and how safe was the event? Excuse me. The workflow metrics, exact screening cycle time, staff burden, and physical visit length, no-show rates. If unfortunately, we really didn't have a no-show rate because we were just getting patients that walked in the door. So it wasn't like we had made appointments for them. We could have, if that was the case, and made appointments and got them no-showed, but we did not have that set up that way. When they walked in, this is what they got. And screening performance, like for example, some of the patients could have had a false positive, negative rates, and there was a lot of decrease in the threshold for this clinic population. Even language barriers, some of that concern was there. And we, when it comes to equity and access, we definitely had the access for and the equity. We were seeing patients of all walks of life, all various ages, over the age of 30, ethnicities, language, insurance, referrals. So a lot of that, we took that into consideration and made sure that these patients were taken care of appropriately. But mine so, we should have been making sure that these patients, we could have you can move forward with some of these. And these are some of the things that we were, when we look back, like how can we make a difference in what we're doing? And we also wanted to make sure that patients were satisfied, they were acceptance of the screening and their referrals. And that was some of the stuff that, if patients refused, I didn't have a leg to stand on. I wasn't going to go back and say, well, this is important. I mean, I let that up to the doctor, but it was definitely something that I wanted to continue with moving forward. And then also the cost of sustaining this, like, do they have insurance? Do they have a way to get the cost of the new high risk identification? Are they reimbursable? Can they go and see the pulmonologist? And those are the things that we were looking at when we were asking the questions. So some other future exploration, like I kind of brought on earlier, implementing this at least 6 to 12 months as a follow-up, looking at completed sleep studies, which would have been very interesting to see who, like I said, who did it, who didn't do it, who's adhering to the CPAP, who is doing, are there any patient-reported outcomes that we didn't choose, and what kind of clinical markers were changed because of they went and had their sleep study. So for example, did their A1C decrease? Is their blood pressure decrease? What does their BMI look like? Are they making a difference? Are they losing weight? So those are the things that I would have loved to have been able to explore this project. And then also to track the process. How are they doing? When they're getting screened, is it positive? Are we able to get the referral from point A to point B? If there's a no-show rate, can we make one? Because there wasn't one, we didn't have that opportunity. But like I said, we just grabbed whatever patient walked in the door that was there at the office. And then do an ad run control chart for ongoing monitoring, charts, any rules that we had. So there was definitely future for exploration and tracking the changes that we could have made in this project or moving forward. So again, future exploration. This was something that I thought about when we were talking about how we can move forward with making change. So developing a better EMR prompt in their system would have been great. Automatic scoring would have been really easy to be set up. I would have loved to have that set up. Referral order sets. So if something gets automatically referred, they get sent over and it gets automatically done and sent over to the pulmonologist. Telehealth support for referrals would have been great. Scripting brief counseling on OSA, multilingual materials. Now, in my project, I did have to do multilingual materials, so I did have that opportunity. And most of the staff were Spanish speaking and the patients were Spanish speaking, so it made it a little bit easier. But scripting the information, that was already taken care of when we did the start of the project. And some staff refresher. If we found any new staff, that would have been a great workflow would be to educate new staff and periodically just update them and say, hey, just want to make sure that you're good. You have any questions? When you ask the questions, how are the patients? Are they receptive? That kind of communication. That would have been great to see. And then evaluating the stop bang versus the no apnea Berlin in this population. It could have been a comparison approach, or even consider step wedge or concurrence control to screening inferences. So it would have been, we could have done multitude number of things to explore this project. And then stratifying the performance outcomes. So really getting the staff and the information and how well we did, and to take that, it would be great to have that opportunity to do a 6 to 12 month communication or education to see how we do, and then even to target any under-referred patients that didn't come our way, just to see how if there was any goals or things that we can help with communication. Again, some of the main takeaways. Again, OSA is underdiagnosed. The screening, it does improve detection. The stop bang is definitely effective, and it is a nurse-led model. It doesn't have to be a medical, an MD. It doesn't even have to be a nurse practitioner or a PA. It could be nurse-led, ask the question, get the information, and then say, hey, doc, you have this patient is screening positive, just want to let you know. And we want to make sure that this is scalable and sustainable to make it easy for the staff and the patients to get care and treatment. This is the results in the 8-week time. Again, the minimal flow, workflow disruption, supports evidence-based practice, supports patient care, improves patient care, increased referral. So again, it was something it was a project that was worth doing. Some of the ethics, HIPAA compliant, retention, destruction, all of that stuff was already discussed earlier. And the takeaway, like I said, this was a very busy clinic, systematic screening operationalized, and an ongoing PDSA cycle. So again, this is something that we could have continuously had upkeep, and mobility. And here's the questions. Does anybody have any questions or?
Thank you so much, Dr. Flannery, for your presentation. It's evident that you're very passionate about this topic, and this we'll go ahead and open it up for questions right now to the group. And I will begin. I'm curious, you talked about the target population that you selected was 30 years or older. Was there a reason for that target age range? And would the tool be useful for younger age groups?
Yes, absolutely. We chose this just to make it very simplified for the office because it was an adult primary care office, and I didn't know at that point how many um, what the age group was, truthfully, but I did see some 18 to 25 area that we probably could have spoken about sleep apnea. And funny that this office actually was doing weight loss management, so she was seeing some obese patients, and really we probably could have uh, chosen a higher or lower age group to work with, but we chose this one just to see where we fell. Um, and we did have two patients that were positive for sleep apnea that were under the age of 30. Like I said, because they were being observed for obesity. So yeah, I'm sure we could probably explore that also in that time period. And if you think about it, I mean, how many kids with sleep apnea now, from tonsillectomies or pre-tonsillectomies that have sleep apnea because, you know, and they're small. So yes, absolutely could have made it a younger population, and that's a great question.
Thank you. I'm going to look to see if anybody asked any questions in the chat. Everybody's saying it was a very interesting, wonderful presentation. You talked a little bit about the resistance of your staff members in the initial implementation of this process. Can you just share a little bit about how you were able to garner that buy-in?
Yeah, so the staff were very resistant because they didn't want any extra work added to them. So what I did was I actually worked with them. I didn't just leave it for me to let them do. I gave them the information. I actually went in with the patients. I asked the questions. They saw how easy it was that I was asking. It wasn't anything much more than their vital signs when they were talking to the patient. So it made it a little bit more I appeased them a little bit. So after that, they're like, wow, this isn't that difficult. So yeah, I can move forward with this. And then they were much more reasonable and were able to do the project with me.
That's excellent. And did you feel that after giving education to the patients on how sleep apnea impacts their health in more serious ways, did you feel like the patients were more willing to follow up with further exploration or sleep studies or anything like that based on the information you provided?
Absolutely. And it's funny because most patients had their family members with them. So the wife would hit them, saying, see, this is you. So it definitely was they understood the ramifications, and I believe that, like I said, my hope would be that they followed up and they did the sleep study. You know, who knows? That was not part of my project, so it would have been nice to see that piece of it. And I would have loved to have seen it, but yes, the patients were, and the family members were very receptive. And, you know, I didn't put it as you know, a problem, but I did educate them and say, hey, you know, you're overweight, you have high blood pressure. There's some things that we can help you with, and one of them is the sleep apnea. And they really were very receptive to the education, which was nice.
That's wonderful. We do have a question in the chat. Do you have, so the question says, do you have any tips or suggestions for someone who's wanting to implement this project in their own clinic? Or is there anything that you would have done differently in the implementation?
Education, education, education. So basically what it came down to is making sure that I educated the staff, I educated the physician to make sure that the physician was comfortable with what we were doing, because making sure that the whole picture was spoken and they were aware about it. It wasn't like you know, I was working on my own. I had to engage them. So that was my biggest problem, is the lack of engagement. And once I got them all engaged, and I'm not talking about just the patients. I'm talking about the front end staff being supportive and being engaged, the medical assistants in the back being supportive and engaged, and making sure that we were all talking the same language so that we could speak to it. So it was like part of their their daily conversation. And that would be my biggest takeaway, was to make sure that the communication was there for everybody, so that way the questions, if I walked away, there was somebody else available to answer that question, and you didn't have to wait for me, and there was no waiting and there was no delay, and to move forward with that. So it definitely was education is a big piece of it.
That's great. I agree with that. There's another question in the chat. Can you speak to the reliability and validity of the screening tool that you used? I know you spoke a little bit about that in the presentation, as well as some of the other widely used tools. Maybe talk about the selected tool, the stop bang screening tool itself, and and then a further question around the population, because you did say that you had a specific population, Spanish speaking population that you were working with. Second follow-up question, is the tool maybe less effective or require adaptation for certain populations? But let's talk about the reliability and the validity first, and then you can answer the second question for us.
So this tool is actually been utilized for quite a long time, and I went through. That was one of the things that I had to go through when we were discussing trying to find the best tool to discuss the stop bang. And this is something that we use here in pre-surgical testing. So I believe, you know, from the studies and stuff that I've read, that this is a very reliable tool, and that's why I chose to do the stop bang. We actually even use it in my offsite pre-surgical testing and in the hospital. So this is one of the things that we utilize when we're seeing patients preoperatively, and making sure that the patient's information and education and clinician and background is all available. As far as it being reliable, I'm sure there's multitude number of tools that are out there. This was the one that was the most reliable and easiest to use for me. But I'm sure I would welcome anybody else to come up with another project to look at the validity of both of, one of the other tools that's out there to see if they, will have an operational difference or with the patients that we have.
Mm-hmm. Yeah, and you did mention that you used an interpreter to support the screening, so that would be an adaptation for that particular population.
Correct.
Thank you for all of that. There was another question. What challenges did you have to encouraging the doctors accepting of the program?
Um, well, it was funny because this office, she I had a rough time with her in the beginning because she was more fearful of me engaging in her staff and making the staff do more work than and she wasn't supporting me as as the student as I was doing the project. So and not to say, I mean, once we got going, it was much better. I said, and I kind of just, I had to put it out there, say, this is my project. This is what we decided on. If you want me to do something different, that's great, but this is what had already approved. So what can I do to support you and the team so that way it's not as stressful? And one of the things that I did was, like I said, I went in with with the patients and I helped them, you know, uh, even though it was a more Spanish speaking population, um, I was able to, you know, I had Spanish interpreters, I had the Spanish um, information. I translated everything already back into Spanish for them. I had all the education in Spanish, so it it really just came to I needed to make sure that I had um, somebody there to speak with, and that was a little bit more vocal and can speak to the Spanish than I can. But we did have some other languages that we had besides English and besides Spanish that we had patient that she worked with. And we had the language line. We were able to communicate and ask the questions. So it wasn't as difficult as it seemed.
Mm-hmm. And I guess my follow-up question, if we begin to find patients with sleep apnea as a more common condition, talk a little bit about, how further exploration, the patients, are they covered by insurance for sleep studies or the sleep mask? And is the cost of this treatment ever a barrier to the final outcome of the screening process?
That would depend if the patient, that's a great question, by the way. That would really depend on the patient and if they have insurance. If they don't have insurance, then yes, that's a barrier that we'd have to work with the patients and the providers to see if there's a way that we can support them. Because that would be the only thing that one of the only things that I could think that we would have a barrier for. Most patients can get a sleep study, and they have a great one now that the patient do at home. And basically, what happens is the patients will get something mailed to their homes, and then they complete the study that day, that night, and they mail it back. There's nothing else that they have to do. They don't have to stay overnight. They don't have to, it's in their own homes. It's something that they do on their own. Um, and I guess barring from that variability, what information can we get out of that? That's something for the pulmonologist. But for the most part, that's something that we can obviously make changes or challenges for.
Mm-hmm. All right, let's see. I'm going to open it up one more time for questions. Feel free to open your mics or type them right into the chat box. Thank you all for joining today. And thank you, Dr. Flannery, for your wonderful research and very informational presentation on your results.
Thank you.
And yeah, very nice job. Great way to kick off the week. If
I
there,
have a question.
okay.
Yes, I have a question, Dr. Flannery.
Sure.
This is very interesting. I thought you did a great job of applying your knowledge as an advanced practice nurse to looking more in depth at apnea problems by screening in primary care. I thought that was really genius. Um, eh, have you, what occurred to me is that when new patients come in, they usually fill out an automated history form before they
Hmm.
see the primary care provider. I'm wondering if you could consider in the future doing a pilot with maybe partnering with a pulmonology department and developing, either using this tool or another tool and adding screening questions to an automated history form and training those providers to look at the scores and, intervene early on. It's just a thought.
That's a great thought. Yeah, that's one of the things that I looked at when we were talking about it, like next future state, like what can we do next steps? And actually, I would love to have known the patients that were positive, did they actually go? And are they following up? And is there a difference in their physicality? Have they made changes? Have they made adjustments? Are they doing better eating? So yeah, that's a great question, and I thank you for that.
I'm thinking maybe if you partnered with a pulmonology department, maybe their staff could do the follow-up, work with you, collaborate with you, and I mean, because they probably would be the ones who would be providing intervention.
Yeah.
And also looking at adults versus adolescents or adults versus children. From what I've read, there are some new masks available that are much more user-friendly for children and adults so that staff who are familiar with this treatment could then share that information with people who are at risk and say, look, you don't have to go to bed now with this big contraption. We have this small mask we can put on and it's comfortable and it will help you.
Hmm. I actually have to say to you, I am a sleep apnea person, and I have sleep apnea. And my daughter yelled at me and told me that I needed to go to the doctor, and I did. And I had the test done, and I did everything that I was supposed to do. And I have to tell you that my sleep is much better than I have ever had it in forever since I've gone and did the sleep study and do this the I wear the mask at night. It's very comfortable. It's like my baby. I say I'm putting on my baby. Um, my dog doesn't like it too much, but it's very comfortable. The masks that I have, they're nice and soft now. It's not like how it used to be. And there are other masks that are available, like you said, that make it much more amenable to patients to wanting to do the testing or at least wear the mask because a lot of times they don't want to wear it. But I don't have a problem with it, and I'm very comfortable with it. And it's 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 very comfortable.
Well, that's just wonderful. And I'm so glad you're doing this. And I would encourage you to look at this as a pilot project that you can build on in all the years ahead. Because I could just envision this being built on over time and refined into something really, really beneficial to a huge number of people.
I agree. I agree wholeheartedly. Thank you. Oop, I think I sorry.
That's all right. Okay, well that concludes our first research presentation for our colloquium week, graduate colloquium week. Thank you again, Dr. Flannery, and we appreciate your time. We appreciate everybody joining us today and hope you all have a great rest of your day. Be sure to check in throughout the week for additional presentations.
Thank you. Thank you so much, everybody.